make sure our masks fit snugly against our face with no gaps. There are lots of ways to do this. You can wear 2 masks. You can knot the ear loops of your mask and tucking in the extra material, especially right around here and right on the sides of the mask, or using other mask assistance devices, or even an N95 mask. We also need to keep washing our hands, watching our distance, and limiting the time we spend with people who don't live with us. And a reminder that we want to make sure people get tested. Testing remains so critical to our efforts to interrupt transmission of COVID-19. Now let me share some updates on vaccines. As of February 22nd, more than 1.4 million doses of the COVID-19 vaccine have been given out in the state of Washington. That is remarkable, and it's a significant jump from where we stood in January when we had only administered about 29% of the vaccines that had been delivered in the state of Washington. We are now administering more than 75% of the vaccine. In fact, we have exceeded the 85, 90% on a couple of days as well. So that is great news, but we still have a lot of work ahead of us. We want to make sure every region across the state has the vaccine. It needs to give shots to people who are currently eligible. We're now reviewing where we may have gaps in allocation or distribution in order to address them, including in several counties impacted by second dose reallocations in recent weeks. And Michele Roberts is on, and she's going to be able to provide some additional responses if there's some questions about that. Our 4 state-led mass vaccination sites continue to do incredible work. Since opening January 26th, they've given out more than 60,000 doses of COVID-19 vaccine. In particular, I want to thank all of our partners who got our Spokane site off the ground, and I had the chance to visit that 2 weeks back. DOH, Department of Health, is now running the site alone, but we could not have gotten started without the support of several incredible community partners on the ground, including the Community Health Association of Spokane, or CHES. CHES had less than 2 weeks to plan and implement the site, and despite that challenge, they were up to the challenge and ensured site operations were smooth and patient-centered, and they came off seamlessly. 14,117 vaccinations have been administered at that site since it opened. We're so proud and grateful of the work of these local partners to make it happen. So I really want to thank CHES and everybody else in the Spokane area, as well as the other 3 mass vaccination sites, and the work that's happening across the state with our local health departments and all of our public and private partners who've done just an incredible job to help us get so many vaccines into the arms of Washingtonians. I have a couple more updates to share, and then I'll turn it over back to you, Corey. First, I know there's still a lot of interest in when we will get the vaccine race, ethnicity, and age data that we shared previously that we're going to be incorporating into our dashboard. We're working hard to make those updates and expect to complete the process by the end of this week. So we're hoping that either by Friday or by this weekend that we should be able to get those updates completed. And we're hopeful that no later by Monday or Tuesday of next week, those will be up and running. Finally, we announced the release of a new report on schools. I know this is of interest to so many people across the state of Washington, by the Institute for Disease Modeling yesterday. And I want to thank Daniel Klein for being here today. He's going to be able to provide some additional details on this, but let me just give some high-level highlights here. That the report provides a step-by-step look into how schools moving toward in-person instruction can continue minimizing COVID-19 risks. The report follows several recent developments on schools that we've all been watching. Earlier this month, as you know, after the CDC published new school reopening guidelines, our Department of Health released its own survey on the relatively low number of school-based clusters reported in our state, and a new playbook for supporting school-based testing. It's important that a lot of folks have been talking about vaccinations as being a prerequisite for reopening schools to in-person instruction. What I would really want us to focus on are the 2 prerequisites in my mind that are key for school reopening. One is keeping community transmission low, which means that's what all of us as adults can do by wearing our masks and all the other preventive measures. That is going to be up to us. And number two is following prevention protocols in schools on the ground. That is absolutely critical. Those two prerequisites are absolutely important in making sure that our schools can go back to in-person instruction sooner than later. One of the most important highlights of the new report is that the rate at which COVID-19 is introduced in the classroom is proportional to the prevalence of COVID-19 in the community. Further, just highlighting what I had just said, for a given school population over a given period of time, a simple calculation based on these results can estimate the number of COVID-19 introductions the school can expect, of course, within the limits of the model's assumptions. And Daniel can provide some more details on that as well. I'm glad to have the Institute of Disease Modeling join us today to review the report findings in detail. And I will say they have been an incredible partner, and not just this, but so many modeling efforts across the work that we've been doing for months and months and months. And they really are just key partners of ours. And so I just want to thank them for their ongoing tireless work. Computer modeling efforts like those in the new report help deepen our understanding of how these factors affect each other and what we can do to reduce health risks for everyone, students, teachers, staff, families, and ultimately everything we can do to get our schools reopened safely in person. We also have Dan Laster from the Vaccine Action Command and Coordination Systems Center. That's a mouthful, but it's short is the V, capital V, capital A, capital C, capital C, capital S, VACCS Center, here to provide an update on public-private partnerships. I really want to thank Dan. He's been an incredible energy into our department over the last, I think it's been about a month or 6 weeks, if I've got that correct, a month? Oh, it feels like it's longer. And we're seeing incredible progress that Dan is going to be talking about in the VACCS Center's work with over 20 partners offering to partner with the Department of Health. And again, harnessing the power of the private sector as we continue to do our work moving forward, but also recognizing that we do not want to leave any stone unturned as we continue to make things as seamless and as best of an experience for the state of Washington and our residents. The center has 5 work streams with a total more than 8 projects in motion. Dan will share a tremendous amount more about these projects, several of which are already delivering benefits to the people of Washington. So I know that was long-winded. There's a lot of information. I'll be very honest. I could have gone on in a lot more detail on each of these projects, but fortunately, I've got incredible colleagues here with the 2 Dans that are on, as well as Dr. Lindquist. We've got Lacy Fehrenbach and Michele Roberts. And I really just want to recognize that this is a team effort, and our team is incredibly dedicated to the work that we're doing. I know that we have at times challenges, and it's not how you get the challenge on your lap or your plate. It's what you do with the challenge once you get it. And we're doing everything we can to continue to move our efforts forward. And I think our vaccine progress from 29% in early January to well over 75, 80, 85 at times percent is just an indication of just the incredible progress that we've made because we've been working with all of our partners on the ground who have just been so tireless in the work that they've been doing. So with that, Corey, I'm going to turn it back over to you.
Thank you, Secretary Shah. Next, we'll go to Assistant Secretary Michele Roberts.
Thank you, Secretary Shah and Corey. I'm Michele Roberts, and I lead the COVID-19 vaccine planning and distribution team for the Department of Health. I want to start by saying how proud I am of the hard work of our team, our providers, and the public, local public health, and the public as well, especially this week, as we've been working so hard to get back on track following last week's shipping delays. This work of a COVID vaccine campaign is hard, and incredible things are happening. If we step back, it's important to remember that this is something that we have never done before in our lifetimes. We're trying to vaccinate the entire population in 6 to 7 months. It is taking a lot of grit, perseverance, flexibility, continuous quality improvement, and most importantly, a commitment to saving lives. I know the nationwide winter storm delays made it tough last week. Many providers had to cancel or reschedule appointments. The good news, as of this morning, almost all orders for the past 2 weeks have shipped. And this week, we're making up for lost time. Tuesday, our state-led mass vaccination sites set a record administering 5,000 doses in a single day. That's incredible work. Our 3-week forecast of vaccine supply is also looking up. Next week, we expect to receive 280,000 total doses. And by mid-March, we expect to get more than 310 total doses of vaccine. Also, if the FDA grants Johnson & Johnson its emergency use authorization, that means even more vaccine will be coming to us next month. The FDA will meet tomorrow to review the emergency use authorization. If it's granted, the vaccine will be further vetted by the Advisory Committee on Immunization Practices at the CDC and the Western States Scientific Safety Review Work Group. If everything goes well, we could have this vaccine in our state later next week. We did get our first allocation numbers for this vaccine from CDC today. And if it gets EUA approval, Washington will be allocated 60,900 doses of the Johnson & Johnson vaccine next week. We're waiting for final guidance from FDA and the CDC before we finalize plans about where to send that vaccine. Recently, the FDA revised Pfizer's emergency use authorization, adding another dose to each vial. Certain needles are needed to administer and that 6th dose from one vial rather than 5. The federal government is sending updated syringes and needles to make sure we get that extra dose. This change is subtle, but the extra dose adds up and gives us an opportunity to administer more vaccine, which is our goal. Although allocations are trending in the right direction, we are still not receiving enough vaccine to meet demand. This week, providers requested more than 430,000 doses, and our allocation again was just a little more than 260,000 doses. We all know demand for vaccine is high. We want to make sure every region across the state has the vaccine it needs to give shots to people who are currently eligible. Due to second dose reallocations, there was a gap in recent weeks, but we're working to fix this. We're having conversations with local health departments, providers, medical partners, and community-based organizations. We also have partnerships with organizations like the AARP, DSHS, and more. A lot of these are invisible efforts, like pop-up clinics at churches or community centers. But we are confident we are moving in the right direction, and any vaccine that gets into our state helps protect all of us. As always, I want to end by thanking our partners and the public. Last week was a lot of work, and weather delays brought us some unexpected challenges. Thank you for being patient. If you're waiting on vaccine, please remember your turn is coming. And Corey, back to you.
Thank you, Assistant Secretary Roberts. Next, we'll go to Dr. Daniel J. Klein.
Thanks, Corey, and thanks, Secretary Shah, for that kind introduction. This is now our 4th modeling report focusing on schools, but this one's a little bit different. So I want to spend the next few minutes telling you what we knew before this report, why we've done another report, and then, of course, what we found. I won't have time to tell you about all the details. It's a comprehensive report, but it's available online. So as in our first 3 modeling studies, this is based on an agent-based type of model. And in that model, we're simulating individual people, their households, their schools, and not just their schools. Within the school, we can simulate individual classrooms and teachers and cohorts of students and all this fantastic kind of detail. And that relies on a tremendous amount of real-world data to inform the model on what those structures look like, what infections look like over the time course of the infection, how long they last, and differences from one infection to the next. And so, just as Secretary Shah highlighted, even from our very first report, Schools Are Not Islands, we found 2 main things. The first is that in-school countermeasures are really important. Those non-pharmaceuticals, or I'll say NPI. This is the mask, the hand hygiene, the distancing, cohorting, ventilation where possible. These are really effective in keeping outbreaks small and reducing risk. And the second thing that we saw from the very beginning is, well, it depends on what's happening outside of schools too. Schools aren't islands. As we continued this work, we got better at producing these models and analyzing them. We were able to add hybrid scheduling and K5 phase-in, as well as analyzing the impact of various diagnostic screenings. This is testing everybody, even if they don't have symptoms, weekly or fortnightly, that kind of thing. So then why another report? Well, those previous reports that we had done were specific to a particular place and a particular time. So like King County at the end of October. And we've all seen the situation changes so rapidly with COVID. So now we're using the same model that we've been using all along, but we're using that model in new ways. And that allows us to explore school-based risks in 3 steps. The first step is introductions. We're looking at how often does COVID show up at school? The second thing is outbreaks. The second step then seeks to explore when COVID does arrive at a school, how far does it get? And the third step is exportations. When you have COVID in a school or classroom setting, what are the chances that we'll get back out into households and the community? This results are more generalizable than what we've done before. We're not investigating a particular place, but what we can do now is to see how much each tool matters and when we need to use those tools. So let's go through the findings step by step. The first step is the introduction. How often does COVID show up at schools? And just as Secretary Shah mentioned, what we find here is a proportionality. If we're able to cut the prevalence of COVID in the community in half, it'll show up at school about half as often. That's great news. We have a number of different analyses here looking at how we can further prevent COVID from arriving at schools. We see, for example, that in elementary schools, we'll see fewer introductions. We see value in some of the diagnostic screenings. For example, a weekly antigen test could reduce introductions by as much as 50%. We see advantages to some of the school scheduling, the K-5 phase-in and hybrid, as well as teacher and staff vaccination, which can have a 10% reduction on the introduction rate. We also explore the source of introductions, whether they're students, teachers, or staff, as well as the timing on when they're likely to occur. And overall, we find that these kinds of countermeasures are able to reduce the frequency at which introductions occur, but we can't completely stop it. So that brings us to the second step, the outbreak step. So if COVID does make its way to a school setting, how far is it going to get? And some of the good news here is that we have lots of tools and countermeasures that can ensure that if it does get to a school, it stays very small. Maybe it doesn't even get to a second person. And the key finding here is just a classic epidemiological result. You all have heard about the basic reproduction number, this R number, right? And usually we talk about it at a whole community level. And it's bigger than 1, that means each infected person is on average spreading to more than 1 person. So 1 to 2 to 4 to 8, and you can get this big growth. And that's why we want to have this number less than 1. And so we can apply that same idea in a classroom or a school setting, a same sort of thing. And what that really shows in this result is that when we're able to implement those non-pharmaceuticals, the masks and hand hygiene, distancing, and so forth, we're able to keep those reproduction numbers less than 1. If COVID were to come into a classroom setting, it probably won't make it very far. And that seems to be a consistent finding with what we see in some of the states' data on outbreaks. There was a report recently showing that the median outbreak size was about 3. And this just speaks to the school administrators and classrooms that have been able to implement these countermeasures to ensure that outbreaks don't grow further. If there are, however, gaps in those non-pharmaceuticals, we're not able to implement all of those layers, or perhaps due to the more transmissible variants, the B117, perhaps B351 as well, then what the model shows is that you are maybe then going to see larger outbreaks. And then that's when those other layers become so important. Diagnostic screening, perhaps weekly or every other week, perhaps stepping up symptom screening. And there, the value is detecting those outbreaks while they're still small so that we can have a response either through contact tracing or reactive closure. A couple other little things to tell you about here. We explored as well school scheduling, and we find that hybrid school scheduling actually does really well to keep school outbreaks small, and there's an explanation for that in the paper, as well as teacher and staff vaccination. Not only is there an individual benefit to recipients of those vaccines, we also find there's a transmission benefit in reducing outbreak size as well. The impact isn't as large as, for example, hybrid scheduling, but it certainly is there. The third and final step in this analysis is exportation back out to the households and community. And we've explored this extensively in our first 3 reports. And basically, it depends on how often COVID comes to schools and how far it gets when it gets there. So the sorts of things we've been talking about. So overall, I think we see that introductions are going to happen less often at lower prevalence. So really focusing on keeping community prevalence low. And if we're able to implement those countermeasures, the non-pharmaceuticals and so forth, we'll be able to keep that reproduction number in schools below 1, and hopefully outbreaks will be infrequent and won't grow very large. However, the gaps that may occur due to incomplete implementation of those NPI or additional variants, if that does happen, we can still keep outbreaks small by detecting them early and reacting. Those vaccination is of course a key topic here, has tremendous benefits to the individual, as well as allowing us to reduce introduction frequency and outbreak size. So now we've extensively explored this school questions across our 4 reports. And the challenge really at this point becomes putting some of these ideas into practice. We're really appreciative for the school administrators, the educators, and everyday families who are facing these challenges head on. So that's what I wanted to tell you today. I'm happy to take questions either if we have time here or afterwards. And back to you, Corey. Thanks.
Thank you, Dr. Klein. Lastly, we'll go to Dan Lassner.
Great. Thank you, Corey. And thank you, Dr. Shah, for the introduction. It's Dan Lassner, director of the VACCS Center. And Dr. Shah was off a little bit, although it feels like it's been longer. Actually, tomorrow will be 1 month since I started. And I just want to start by saying it's actually been extraordinary, the outpouring of offering from the private sector to support the department in the effort to achieve mass vaccination in the fastest and in the most equitable and efficient way possible. And I'm just going to speak to a few of the projects underway where we actually, in less than a month, have delivered to improve things. The first I'm going to talk about actually is in Michele Roberts' world, which is the supply world. And candidly, this is one that really is under the hood for Washingtonians, but it's critical. And that is every week, Michele and her team have to make the supply allocations that she's spoken of. And these are very complex, and getting them right with the special emphasis on equity requires technological support. Our private sector partners are supporting the team that literally has worked overnight many weeks to get this done. And so we're on an iterative path to make it easier and easier, and to continue to do the great work of making these very difficult allocation decisions. And the more the data is real time, the more we can fine tune it so that we do get the supply where we need to achieve the equitable goals that we all want. Moving to a different front, one that candidly I know is frustrating a lot of Washingtonians, and it is the issue of daylighting information about appointment availability. Now, I want to just first step back and make sure that one of the challenges we all know we have is supply scarcity. So we are doing work, we can't solve the supply scarcity, but we are looking where the puck is going, and we know that supply is increasing. We know we will move to the next eligibility phase. And the question is, are we going to make it as easy as possible and not as frustrating as possible for Washingtonians to know where the providers are, where they can make appointments? And we are on an iterative path to progress there. It's a long journey. We're at the beginning, but just last Thursday on our vaccine locator page, we introduced enhancements, a better map. There are over, from an equity lens, there are over 20 languages in which you can translate our page. Now, of course, provider pages that we link to, those are in English, so there still are challenges. We recognize that. We're looking forward in the next couple of weeks to having greater improvements. And this really is an example of an amazing dream team of both the Department of Health, the IT team working diligently, and a whole host of private sector partners. And I think this is a great example. We're also looking to the volunteer community among our citizenry. There are a group of programmers who have gotten together very quickly, COVID-WA, and they put together a site. They are in our tent working with us. I was actually talking to one of the founders yesterday. So we're all trying to work together as one community. And it also just highlights the entrepreneurial DNA in the state of Washington, which is reflected in the business community and just individuals. So we are really hopeful that we're moving in the right direction to reduce the frustration, to learn the necessary information. The other piece of the puzzle that's really helpful if you are digitally savvy, but we know that many of our citizens aren't and may not have the same access to computers. And so that's where our call center is critical. And here, again, we do have limited resources, and this is where the amazing offering of the private sector really can help the state. At one point, right when I started, there was a day where at 1:30 in the afternoon, 4,500 Washingtonians were in voicemail purgatory. My goal is to help the state not have that happen in the future. Even when we go to new eligibility, we know that if we're adding 1 million, there are going to be Washingtonians that need help. And I'm really excited about one of our partnerships, which is going to both add to our surge capacity, just so again, people get answers quicker. But not only that, and again, this is looking to the playbook of the entrepreneurial spirit in the volunteer community. There's a group called Vaccine Bookers. And we've read in the news that this is happening across the country. Of course, right now it's in a landscape of supply scarcity, but the supply is increasing. It's really encouraging. And what we want is for not only those Washingtonians who can readily navigate the web to make their appointments, but we want to make it level the playing field with an eye to equity, make sure all Washingtonians can easily make appointments. So we're upping our offering. We're not there yet. This is to come, but I think it's really exciting work. And it goes to making all Washingtonians have the ability to easily make appointments. I'm going to flip to one last area, and this really goes to efficiency and also what Dr. Shah has said to me since I started. The goal is laser focused. We want to get to 45,000 doses a day in the arms of Washingtonians, but we also want to, given what an anxiety-filled time the last year has been, and now the frustration and stresses of not having enough supply, to make it as positive in a bad situation, as positive an experience as possible. And so the work we've done with Starbucks in this regard is really quite exciting. So literally within 4 days of when I started and 4 days of the stand-up in record time, where the mass vaccination sites were set up in Clark County, we had colleagues, really what I call gurus on the user experience and throughput experience, look at our site and make recommendations. Those recommendations have already been adopted. And I'll just give one example. Adding a third lane increases throughput by over 30%. Now, right now, we don't have the capacity in terms of supply, but as our supply increases, we will be able to, in a much more efficient way, get people vaccinated. And from a user experience, one thing that working with our private partners, we noticed is everyone has to sit for 15 minutes. We want to make sure no one has an adverse event. That's valuable time to share important public service announcements. So we're now in progress working with our private sector partners from a communication lens. How can we reinforce the messages? Just because you're vaccinated doesn't mean you don't have to keep masking up, keep washing your hands, keep socially distanced. So that's a great example. We're bringing the private sector, working with our public sector is, I think, leading to exciting outcomes. I'll stop there. There is a lot of other work going on. I'm unbelievably excited and proud of all the work. One of my mottos has been, do no harm to the amazing work for over 400 days that our colleagues in the Department of Health on the front lines have been doing. And we're trying to seamlessly partner with the private sector. And I'm just, delighted with, what is happening, which is really the best of the public sector working with private partners for a common good, for all of us to get back to a new normal as soon as possible. So thanks very much.
Thank you, Dan. This brings us to the Q&A segment of today's briefing. We do have a number of reporters with us today for questions. So just a reminder, if we're not able to get to your question, please reach out to us at doh-pio@doh.wa.gov, and we'll connect with you for follow-up. Our first question comes from Anna at KUOW.
Hi there, everybody. Thanks so much for taking my question. Could you all talk to how far we are towards vaccinating long-term care facilities fully, in particular adult family homes, and how many facilities there are left to vaccinate?
Michele, do you want to take that one?
Yes, sorry about that. Great question. I think we're going to follow up with you on the exact numbers. We were on progress to get all the remaining adult family homes finished last week, but obviously the weather delays and the vaccine delays have pushed that farther out. But we have CVS and Walgreens should be close to finishing, if they haven't yet, all their first rounds of visits to facilities. And then facilities that were not participating in the federal program are being visited by state and local mobile teams. And we have been working through all of those facilities over the last month, but we could follow up via email on exact numbers.
Corey, are you there?
Corey.
It appears we lost our next reporter in the queue. So moving to Arielle with the spokesman review.
Great, thank you. I'm curious how we anticipate Pfizer changing the dose count from 5 to 6, impacting our state's vaccine data and wastage data. And then I'm also curious if we have any idea about the Johnson & Johnson doses, if they'll be prioritized to settings that don't have cold storage and struggle to store our 2 vaccines right now. Thank you.
Thanks, Arielle. I'll take that second question first, and then I'll let Michele and others talk about the 5 versus 6 per vial. We have made it very clear, and I said this at the last press briefing last week, very clear as secretaries of health across the country to our federal partners that we are, we're very optimistic that on Friday the FDA will approve the Johnson & Johnson vaccine, and then shortly thereafter, Sunday into Monday, that we will get approval from ACIP at CDC, and then certainly we're starting to get more information about what potentially even ordering would look like for the vaccine. That's all great news, but what we have said very clearly is that we would like and really are anticipating that the federal government will give some best use guidelines of either settings or populations where this vaccine would be most effective or best optimized in terms of its usage. And so that can include in settings where it's difficult to get a second dose in, or populations where it may be difficult to get a second dose in, or where you really believe that a booster dose is absolutely critical, or where in certain instances with certain kinds of occupations, such as agricultural workers or maritime workers, where it's very difficult to go back for the second dosing, or as you said, with storage issues related to being able to store the other 2 vaccines versus this 3rd vaccine. So there's a lot that we've asked, and we're hoping we're going to get some additional information. Still a lot that we don't know in terms of how this is all going to play out, but we have been asking those exact questions because this is critical to now make sure that when we get this 3rd vaccine, and notice I'm not saying if, because I do believe that it looks like the data that came out yesterday that's very promising, and so it looks like it's going to get approved. Of course, we have to work through and wait for that process to work itself out. Ultimately, that we're anticipating that we're going to get not just the vaccine, but we're also going to get some guidance on its optimal use. And Michele, with that, if you want to answer that first question about the 5 versus 6 doses with the Pfizer vaccine.
Yeah, great. Our increasing numbers, part of what's increasing is actual additional vaccine vials, but also part of the increase in our allocation is the fact that now, for the most part, you're almost always able to get a 6 dose out of the Pfizer vials. And that's how CDC is counting that vial now as a 6 dose vial of vaccine, not a 5 dose vial. But as you know, that really depends on having the right types of needles to do that. And CDC and the federal government, that's really a federal government piece because they're providing the ancillary supplies for the vaccination. So they have worked hard to do several things to eliminate needles where there were any quality control issues, increase manufacturing and molding and manufacturing of the right needles to do this. There's very little supply of needles on the open market at the moment. So CDC, when working with MCHES and others, are kind of purchasing from many different manufacturers. So it will take a couple more weeks, we think we're hearing from CDC, to ensure we always have the right type of needles. And so sometimes that means that we may not be getting that extra dose, but we're definitely working with the federal government to move in that direction. And I know that is the goal, to only have the right type of needles that can always get the 6 dose out.
Our next question comes from Kellee at K2.
Good morning. Thank you for taking my question. I know you guys have heard from me on this topic before, and this week we've learned that you heard from Clark County Public Health Director as well as Congresswoman Herrera Butler. We continue to get similar answers, but not a direct answer on why Clark County is getting so much less vaccine than other large or similarly populated counties. And how do you plan to fix this inequity for Southwest Washington? We also would wonder what you say to Southwest Washington residents who feel forgotten.
Yeah, thank you, Kellee, for that question. And let me start with that last part. And I think it's absolutely critical to make sure that the message that you just asked about for our Southwest residents or in Clark County, the Vancouver area, that it's very clear. What we're saying is that you have not been forgotten. We are doing everything we can to get vaccines throughout the state of Washington, and that includes setting up a mass vaccination site in that very area. So we do recognize the importance of that. What I would also say is that we are absolutely, even prior to this discussion with Clark County, we had identified a number of counties where we were proactively seeing that as we went through the allocation process over several weeks, and remember just playing it back out to, first it was hospitals, healthcare workers, and then working through with this 1B1 population, that it was an imperfect process to be able to get vaccines to all the different entities that were asking for vaccine because of the vaccine supply constraints. So it is absolutely something we were already looking at and working towards, which was how do we, in essence, review the information, catch up where we need to, and close those gaps. Now, it is more complex than just a number game or a number equation or a number per capita, because it really is about who the providers are in those areas and what kinds of populations they're serving and what kinds of storage capacity even that they may have for certain kinds of vaccines, and their receptivity to be able to take different kinds of vaccines. So it is all a part of the equation. And so it is a direct answer. There are many factors that are going into this, but I will assure you that we're doing everything we can to look at the data and make sure that wherever we can, especially with this, with some additional vaccine supply that's now come into the state or coming into the state over the next several days to week, week plus, that we do hope that we're going to be able to catch up some of the counties where the allocation gaps are being seen. In addition to that, we also recognize that there are also constraints that we're going to have, because we're also trying to make sure that race and ethnicity and other factors are factored in. So again, it's not just about numbers, it's also about making sure that we're looking at all those complex factors that go into the mix. So I hope that helps. And Michele, I don't know if you have any additional thoughts about this question or anything else you wanted to add.
Yeah, there's a couple pieces I want to add. One of the big challenges, there's two reasons that have driven the couple of counties or several counties who are behind, Clark County being one of them. And like Dr. Shah said, we are aware of this problem. We had been reaching out to these counties over the weekend to work to resolve it. One of the biggest issues is the disconnect between what providers are ordering in that county. And are they ordering Pfizer vaccine versus Moderna vaccine? We've been really clear over the last several weeks about the challenges we've had with more second doses being requested than first doses, and we've been prioritizing second doses. Most of that problem has been with Moderna vaccine, and then in many of these counties where we're seeing this mismatch, what a lot of their providers are mostly requesting Moderna vaccine, which we have very little available for. So in our outreach over the weekend to these counties was specifically to say, we need to work with you, local government, help us find more providers in your county who can take Pfizer vaccine, because that's where we have enough vaccine supply right now. So in those counties, we are surging Pfizer vaccine already this week into the counties, and we'll continue to do that over the next couple of weeks. And it's just really important. I know it's easy to want to have a preference about which vaccine you want to get, and they're all different minimum order sizes and different storage and handling requirements. But when we have such a limited supply of products, we really do need flexibility in our provider community about what types of vaccine they're taking. We know that makes it harder on the ground level, because it is harder to have two different types of vaccines in your refrigerator and freezer, but it's absolutely the situation we're in with really limited resources. So that's why we're working with local government and then quickly identifying a lot more places where we could get Pfizer vaccine. The other one piece I want to say, that is another piece, is providers who aren't meeting the 95% requirement. It is really important every week that providers use all the vaccine they're given. We have heard about the variants and about, people are still dying in our state. So when we have such a limited resource, we want every single dose used each week. We are looking at the list of providers who are not meeting 95% requirements, and their orders are being reduced for the following week. So that factors in sometimes to why counties may be slightly behind.
Our next question comes from Megan with the Puget Sound Business Journal.
Good morning. Thank you for taking my question. I believe this is for Michele. I'm wondering where we need to be as far as supply is concerned to fully utilize all the businesses who have been reaching out, offering their facilities, and when we might get there.
Well, the answer is we need a lot more supply. So right now, like I said, providers are requesting more than 430,000 doses each week. And we said we have about 260,000 doses. So even our state mass vaccination sites, our local mass vaccination sites, the mobile teams that the state and local are doing, our providers, pharmacies, they all have more capacity. In fact, we think on the low end is 45,000 doses a day. We did some more work looking at the data, and we have I believe it's over 140,000 dose capacity in our state if we had enough vaccine. And that's just from all those providers. So we have a lot of work to do. And local governments and community partners have done a ton of planning to figure out how can we rapidly stand up additional sites and increase capacity at our existing sites. So we need a lot more doses to get there. We're moving in the right direction, and maybe by the end of March, we'll be in a much better place.
Dan Laster, did you want to make a quick comment also about the business piece?
Yeah, the only thing I would just add there, really, in some ways echoing Michele's comments. I mean, the business community and just across the state, the desire to help out, set up pop-up clinics in different communities, And the challenge, as I see it, is really what Michele said, and hearing Andy Rose, who's overseeing a lot of the efforts, is right now, I think, Michele, correct me if I'm wrong, it's about 300 providers that are getting vaccine on a regular basis. We have over 1,200 providers that the state has analyzed whether they can avail themselves of the vaccine. And the reality is we just don't have the supply. And so, we have to entrust that Michele and her colleagues, looking at, these multiplicity of factors, are taking this this very valuable supply and deploying it as wisely as possible. As the supply increases, then we'll be able to, I look at it as almost a sprinkler system, and which sprinklers we can turn on, really complicated. And in fact, we have over 1,300, which is great once we have supply, but we're not there. So this is where it's not only from, the citizenry patients, in fact, all of the local health jurisdictions and private organizations that want to help, we really need the patients so that we can coordinate and plan most effectively. So I would just add that.
Thanks, Dan.
Our final question comes from Carla with the Associated Press.
Yeah, thank you for taking my question. You started to address this with Arielle's question about the Johnson & Johnson single dose vaccine, but if you could dig in a little deeper and tell us about the planning that you're doing now for scenarios where you might be able to deploy this vaccine. I know you're seeking guidance from the federal government. I understand that. What hard to reach populations are you considering? Which providers are you considering sending this Johnson & Johnson vaccine to? And will people ever have a choice of which vaccine they receive?
Yeah, so let me actually tee it up a little bit for both Lacy and Dr. Lindquist to jump in on this. So if they can be ready to, I'm gonna ask them to comment from their perspectives as well. Michele and I have done a lot of talking, but the one thing I did want to make comment is that about this last question, comment about choice. The choice right now, my sincere recommendation to people across the country and in the state of Washington and local communities is that if you have an opportunity, if you are eligible and you have an opportunity to get a vaccine and you have an appointment, get the vaccine regardless of which vaccine it is. Now, you can always have a choice of going to a provider that has one kind of vaccine versus another, but I would really recommend that people get the vaccine. That is the most critical piece of this because we have such limited supply, and there are times where if you miss your appointment or don't make your appointment, that it may be hard to get back in that line. And so I would just really make sure that people do everything they can. Now, at some point, perhaps over time, when we have markedly more supply, you can make some very easier or maybe more facile choices about, well, this provider has Moderna vaccine, this provider has this vaccine, I'm going to make a choice because it's not going to impact my ability to get vaccine quickly. Right now, we're trying to get vaccine out as quickly and as equitably as possible. So absolutely, that would be the message that I give, is that choice is not there yet. Now with that, let me turn it to Lacy and Dr. Lindquist if they want to add anything more. And then if anything else, Michele, you can supplement.
Thanks, Dr. Shah, and thank you for the question. So the first thing, we do really count on those national recommendations. We have tried from the beginning of this response back in January of 2020 to be driven by science. And so, everything I say, like, we are going to wait to see and be informed by what the FDA, the Advisory Committee on Immunization Practices, and the Western States Vaccine Group reveals to us as the full data are released over the weekend. And that will really drive and influence our decision making. In terms of factors we are considering, there certainly are groups that could be harder to reach because they are remote, or they live in congregate settings that we are thinking about, and Dr. Lindquist can talk more about that. But when you heard all of those factors that we're lining up from a logistics perspective, we will also think about, how can we use this vaccine to catch counties up on their pro rata? Who are the providers that are best suited to take this vaccine, or maybe least best suited to take some of the others because of their storage capacities? That will influence how we use it when it's a scarce resource. And certainly it's like 3-dimensional or 4-dimensional chess that we're all playing to get this vaccine out as equitably and quickly as possible. And I also want to reemphasize Dr. Shah's point. When your turn comes up in line, take the vaccine. We are so fortunate, so fortunate. It is a miracle of science and the human spirit to come together, and building on decades of work around vaccines, that we have a vaccine, not just one, but 3 good vaccines that prevent severe disease, very effective at limiting hospitalizations and death from this disease. And we have them in little more than a year after we learned about the virus. So many factors will inform our distribution of the Johnson & Johnson vaccine when it is approved. And turn it over to Scott for some special populations potentially.
Yeah, so we have done a lot of thinking about what is the best use of a single dose vaccine in populations that are hard to reach. So here's an example of a population. The maritime or the fishing industry who gets on a ship, who lives in a congregate setting, which could have a lot of racial inequities in that workforce. This is the ideal vaccine for them because you can get them before they go out to sea. They're out to sea for months at a time. Trying to get them a second dose is a real logistic challenge. We've been challenged with this in Washington, where we've had to send the second dose onward to where their next port of call is. And that gets a bit complicated. So a single dose vaccine really makes a lot of sense there. Agricultural workers. So as we get seasonal workers coming into Washington State that are doing critical infrastructure work for our food supply, that is yet another population that the single dose is. But to be really clear about this, our first use of the Johnson & Johnson is to complete all of those folks in 1A, so healthcare workers, all those in 1B before we can move on to these other priorities. And again, I mean, the Seattle Times said it great this morning. The best choice of the vaccine is the one that's available. And I really stand by that. Anyone in my family that was eligible for a vaccine, I would give them that same advice that Lacy and Dr. Shah just gave. If you're in line for a vaccine and it becomes available, it really doesn't matter. I'm talking to my family members now. It doesn't matter which one you take, whether it's Pfizer or Moderna or Johnson & Johnson. If it's available, take it.
Yeah, it's key is, our message has been, do not hesitate, vaccinate, both to our providers and to those getting vaccines. Do not hesitate. We want to get vaccines quickly into the arms of Washingtonians. So thank you for those answers. And Corey, I'll just close it out with just saying thank you to everybody for being on this media briefing. I want to thank Daniel Klein particularly for the incredible partnership with your institute for everything you all have been doing. Just want to say kudos, and please continue to be strong advocates for data and science and modeling, and we just really appreciate that. I want to thank our team, Dan Laster, Lacy, Fehrenbach, Michele, Roberts, and certainly Dr. Scott Lindquist for being a part of this briefing as well. Our team and many teams on the ground have been now over 400 days responding to this pandemic. And it is an incredible lift. And I am just so amazed in just a couple of months. I've only been in maybe about 15% of this time, what I've been seeing of this state, and what I mean by state, the entirety of our state, across the state, what everyone has been doing in the private sector, in the public sector, public health, at the local level, at the state level, our tribal partners, and throughout the entire system. But most importantly, I want to thank our community members. This has been such a difficult process. We know this is a challenge. I just hope that you come through with these press briefings and not just thinking about all the incredible amount of data and information that we want to give and want to provide, but you also realize that we're doing everything we can day, night, weekends, holidays to make this experience better for you and to get these vaccines, which is this latest phase of COVID-19 response, get these vaccines as quickly and as equitably into the arms, your arms, not just someone else's. We want to be able to get this through so you can be vaccinated as quickly as possible. So that's the most important thing, but there is hope here. We are starting to see decreases across the country and across the globe where vaccines have been administered, and we are hopeful that that trend continues. Yes, we're concerned about variants, but we also recognize that we've got a tool here, and we want to make sure that we do not hesitate with this tool, that we vaccinate. And so with that, I just want to say thank you to you. Thank you for everything you're doing. We had a pretty rough week last week in Texas with everything that's going on. Thoughts and prayers to our colleagues in Texas and throughout the country who have experienced these incredible weather events. And I want to also thank all of you, and please be safe, protected, and most importantly, please help us champion messages of health and well-being to all of your colleagues, friends, and family members so we can have healthy communities. And with that, Corey, we will turn it back to you. Corey, you may be on mute. You know, it's always tough when Corey's on mute because we can't actually close out the briefing. So all of us are kind of stuck until Corey comes off mute.
I think you should take us out, Dr. Shah.
All right. I'm going to do that. Thank you, everybody. Thank you for joining. And as we say every week, this video will be available. The full detailed video will be available later on our website and social media. Thank you for our media partners for everything you're doing, and we'll be back next week. Take care.
And thank you, TVW, for the recording and archive.
That's right.